Okay, Assalamualaikum warahmatullahi wabarakatuh. I would like to greet very good afternoon for everybody who has already joined this webinar. It's a very good opportunity for us to see each other again after not being able to see like offline. For this afternoon, PERKI, the Society of Indonesian Heart Association, along with AstraZeneca, we are holding this webinar entitled "Utilizing Potent P2Y12 Inhibitor for Post-Pci patients." So today we have a very special, distinguished guest. The first will be Dr. Dafsah, and secondly will be Professor Stefan James. Will be presenting for us from very far apart from Sweden, right to our home. In this grim time, I know it must have been very difficult for most of us. I would say to all of us during this pandemic. Of course, I would like to greet you. Hopefully, we all keep safe wherever we are. Probably some of us might have been having our quarantine isolation at home, but it's also always a very good moment for us to utilize our time. And right this afternoon, we're going to learn more about the P2Y12 inhibitors from the experts. Supposedly, Dr. Isman Firdaus, our president, the president of Indonesian Heart Association, is scheduled to open this webinar for all of us. But unfortunately, he's having some other arrangements, and he's not able to greet all of us here, and not able to open this webinar. But I think it's all right. We have our vice president here, which is also our first speaker, Dr. Arifa Dafsah Juzar. And I don't think I need to introduce him to all of you, because most of us must have known him already. He is one of the faculty members, a lecturer at Fakultas Kedokteran Universitas Indonesia, the one who has been very involved in many researches in the country. So without further ado, I would like to allow Dr. Dafsah to present his very first presentation for this afternoon, entitled "Optimal Use of Potent P2Y12 Inhibitor in Asia Pacific Population." So Dr. Dafsah.
Thank you, Dr. Dasdo. It's actually it's quite an honor to sit here with Prof. Stefan James talking about P2Y12 inhibitor. So the title is "Optimal Use of Potent P2Y12 Inhibitor in Asia Pacific Population." This is my disclaimer. And as a background, I think we see that the management of acute coronary syndrome varies across Asia Pacific region, and dual antiplatelet aspirin in P2Y12 inhibitor is generally recommended, and for at least 1 year following an acute coronary syndrome, or longer in patient with high ischemic and low bleeding risk. However, there is a considerable variation in DAPT duration across Asia, and a one-size-fits-all approach based on Western guidelines may not be appropriate for Asian population. The genetic, that's because due to the genetic polymorphism, especially in affecting the CYP2 C19 function, is associated with slower rate bioactivation. Clopidogrel have substantially higher in the prevalence in Asian population is 29 to 30%, than in Caucasian population, which is only 15%. And also there is an East Asian paradox, resulting in different benefit and risk profile in the East Asian population, which is have a lower ischemic event and a higher bleeding event compared to the Western population, despite an higher than average on treatment platelet reactivity. So the data generated in Asian patients are limited and rarely incorporated into major international study or guidelines. In that background, I think the Asia Pacific Society Cardiology has convened a panel of 22 experts from 13 countries in Asia Pacific, and they developed consensus statement the use of class drugs in ACS for Asia Pacific region. We try to find the clinical studies in Asian population, but in the end, due to a limited data, we decided that we are creating recommendation assessment, development and evaluation system according to a high, moderate, low, and vary among the 22 authors from 13 countries. High means all the authors are have a high confidence that the true effect is similar to the estimated effect in Asia Pacific population, and moderate, the author would believe that the true effect is probably close to estimation effect, and low when there is a marked difference to the estimated effect in the Asian population, and very low when there is a markedly different from estimated effect. So the consensus was published in the European Cardiology. And for the ST elevation, I think as the recommendation from the guidelines that the 12-month duration of therapy of ticagrelor loading with 180 and 90 twice daily as a maintenance dose, and also prasugrel. So the recommendation for stronger P2Y12 inhibitor for patient in ACS, and also is effective and safe in preventing adverse cardiovascular event in patient with STEMI, and are recommended who are undergoing primary PCI. And this evidence is the recommendation, and the panel agreed almost 100%. And the aspirin and clopidogrel are introduced for thrombolysis. If it's introduced, I think most of the panel agrees that it should be switched to a ticagrelor based on the safety in bleeding from the TREAT trial. So the algorithm for STEMI, you can see there is the eligible for reperfusion could go thrombolysis, and also could go for primary PCI. And dual antiplatelet regimen, the first choice would be ticagrelor and prasugrel. Second choice would be clopidogrel. And for thrombolysis, patient who received thrombolysis therapy, switching the clopidogrel to a delay 8 hours or until the next day, it is recommended, given that the delay 8 hours has least chance of bleeding. And those therapies should be continued for 12 months. And I think it's important also to note that in our population, it's actually 30% patient goes undergone fibrinolysis. So there's quite a big population who goes into fibrinolysis for revascularization, and 70% goes to primary PCI. So I think the use of dual antiplatelet, given the efficacy, should not be considered lightly. And for the non-ST elevation patient, I think the ticagrelor is low and also given twice daily in non-ST elevation. And for those who have invasive strategy less than 12 hours, pre-treatment may not be mandated. And all the panel seems to agree with that recommendation. And in regards to prasugrel, it's recommended only in patient undergone PCI. This is also an no pre-treatment. Pre-treatment is not recommended. It's also feel that it's aligned with the finding from the study and also the recommendation. And in regards of the minimum 6-month DAPT is recommended, there is a few that still feel that it should be more than, should be at least 12 months, but majority agree. As you can see here, that the patient is non-STEMI in the recommendation, revascularization is STEMI guided or early invasive strategy. The first choice, either strategy you use, also the first choice is ticagrelor and the second is prasugrel, and follow with indefinite aspirin. If you look at our registry, that I think the patient that goes for early invasive strategy is 54% always, and the other 50s have a conservative strategy. So I think this is also a major difference in that the patient in our population, especially in Indonesia, there is most of them for non-STEMI undergone a conservative strategy. In terms of prasugrel, I think the evidence is from the TRITON 38 that the prasugrel, as you can see here, it's a reduced event of cardiovascular death, MI, and stroke, and compared to clopidogrel, and it's a number needed to treat 46, and the dose is 60 loading and 10 milligram maintenance dose. But if you look also in the measure for bleeding, TIMI non-CIBG bleeding, the prasugrel higher. So the use of prasugrel reduce ischemic events, but including stent thrombosis, but increase risk measure of bleeding. So the overall mortality, although did not differ significantly between the treatment group, but the risk of bleeding is higher in prasugrel. This is a population done in mostly Western country, but in Japan, they did reduce dose, which is 20 milligram for loading instead of 60, and 3.75 milligram for maintenance dose. As compared with clopidogrel, that's also have a reduction in major adverse cardiovascular event. It's around 23%. And I think it was evaluated through 24 weeks. So in compared to in Plato, I think we are familiar with this result that in Plato study, in across all ACS patients, whether it goes for STEMI, non-STEMI, and non-STEMI undergoing invasive procedure, or non-STEMI undergoing non-invasive procedure, which is conservative. The primary endpoint for CV death and MI and stroke, I can see is much lower and significantly lower in the ticagrelor group, and also mortality, especially in the mortality, also there's a difference. And then in terms of net clinical benefit, I think we can see that the combination regarding the efficacy and the risk of bleeding, you can see that the ticagrelor is also superior than clopidogrel, with number needed to treat 54, and with 250 needed to harm for bleeding event. Okay, for I think this result across all population, ACS population, when it's evaluated in the non-STEMI population, which comprise almost 60% of the total patient, the result for primary endpoint is also consistent, which is significantly lower without the increase in major bleeding. And then if we look at the comparison between patient who undergone, non-STEMI patient undergone revascularization compared to patient undergoing revascularization compared to non-revascularization between the two groups, we can see that the patient with no revascularization has a higher event. Patient with no revascularization have a higher event, but if you compare the group with received ticagrelor and received clopidogrel, it has a lower event, despite that the event is higher compared to patient who go on revascularization. Also in the major bleeding, we don't see any difference in the non-revascularized group, and then compared to also in the revascularized group. So I think the result in patient with non-STEMI and also patient with non-STEMI undergone conservative strategy is also consistent with the primary endpoint in the original study. If you look at the Asian population, which compromised of around 1,000 patients, involving a patient from East Asia and also Southeast Asia, including Indonesia. So you can see that the net clinical benefit on primary efficacy endpoint and also ischemic event, bleeding, and adverse reaction are consistent in Asian compared to the non-Asian patient. Since I think it's worth to note that that the 30% of our population also still receiving thrombolysis, and I think you can look at what happened when you use ticagrelor in a patient with thrombolysis. I think in this population, I think the 20% of the thrombolysis is non-specific. And we can see that the one that received clopidogrel and also the one that received ticagrelor. What we look at also PMI defined as a safety endpoint, the primary safety endpoint, and time to PMI defined first major bleeding at 30 days, and then the secondary endpoint and secondary efficacy endpoint for composite death vascular cause. But this study actually power only to look at the major bleeding. You can see that the major bleeding in this population with received thrombolysis as compared to between ticagrelor and clopidogrel, there is no significant difference. So in terms of causing bleeding, ticagrelor is not inferior to clopidogrel in patients that receive fibrinolysis as a main therapy for STEMI. At 12 months, you can also see that there's the TIMI major bleeding, also plateau major bleeding, and part 3 and 5. There's no difference as we evaluated at 1 year. What about the bleeding risk? So we know that the bleeding has been shown that the episode of bleeding during acute event, it's actually have a higher mortality adverse event in ACS patients. So there is no, for Asian country, there is no specific calculator to recommend it to use. And also 72% agree that the Decker or prasugrel combination should be considered as first line in non-STEMI patient at high risk for ischemia, unless the patient has prior history of bleeding above or the age is above 85 years old, and need to adjust duration of the therapy was based on bleeding risk. And also agree that the PPI should be considered in patient with high risk bleeding. However, still need to investigate the cause of bleeding. And radial access should be used for intervention among patients with DAPT who scheduled to undergo non-cardiac surgery. Consider the risk associated with stopping DAPT or continuing aspirin alone versus delaying surgery until completion of 6-month DAPT. And what's important also need to be a joint discussion between the cardiologist and the doctor who's going to be doing the procedure in terms of risk, assessing the risk of bleeding and also ischemic event. The recommendation is to stop ticagrelor and clopidogrel 5 days and longer for prasugrel. What about switching antiplatelet therapy? Before switching antiplatelet therapy, especially de-escalation, the clinician must evaluate the risk and of possible ischemic event during the de-escalation, and it is necessary to delay de-escalation as long as possible, at least 1 month, and preferably 3 months after ICS event. Although this evidence is low, but almost 90% agree on this recommendation. And then the other thing is, regardless of time frame, reloading is required when switching from ticagrelor to or prasugrel to clopidogrel, unless there is ongoing bleeding. It's also the evidence very low, but 81% agree. How about long-term versus short-term DAPT? I think for standard duration DAPT, most agree is 12 months after ACS. Extension beyond 1 year may be considered if there is a high risk of bleeding, such as high risk and anatomy, complex anatomy, and other general risk factor. And in regard to genotyping, I think due to the lack of positive prophylactic trials in Asian patients, the routine use of point-of-care platelet function to guide the decision antiplatelet is not recommended. And I think ticagrelor also has been shown to be effective among specific populations such as diabetic, elderly, and also CKD patients. I think in Pegasus trial, which is has a high risk criteria, which is a patient above 65 years old and then diabetes requiring medication, second prior to spontaneous MI, evidence of multivessel CAD and chronic end-stage renal dysfunction, less EGFR less than 60 millimeter, and also this population, I think 2,000, almost 10%, a bit more than 10% came from China, Japan, Korea, and also Philippines. You can see that the use of long-term ticagrelor, whether the dose is 60 or 90, there is no difference, but there is a difference between patient who is not receiving a longer term of dual antiplatelet, as you can see in this graph. And in terms of bleeding, there is a TMI major bleeding and minor bleeding. There's a significant difference, but however, there is no significant difference in fatal bleeding or intracranial hemorrhage. And then for total event prevented, for death and combined is 18, death is 6, and infarct is 9, and stroke is 5. And the risk of event for bleeding is and major bleed is 21 without any intracranial hemorrhage. And in the elderly subgroup analysis, the finding was also consistent with the plateau, suggests that antithrombotic benefit will also apply to the age group more than 35 years old. And then the plateau and Pegasus, there is a diabetes subgroup. I think you can also see in the plateau for diabetes subgroup for primary endpoint, all cause of death. And you can see there is the benefit of using tachycardia comparison to clopidogrel, that the event is lower both in diabetic and non-diabetic group. And the use of ticagrelor consistent lower in both subgroup without however increase in the major bleeding. And then in the Pegasus group for the higher risk patient, also with diabetes, you can see that also consistent that the patient with diabetic have higher primary endpoint or also death, but patient who receive ticagrelor has a lower primary endpoint and also CVD in both group, diabetic and non-diabetic. What about patient who has renal function, reduced renal function in the renal sub-study? I think this is also consistent with the general population in this patient. If we compare patient who has lower eGFR as compared to population with higher GFR, is also with higher GFR have a higher risk for efficacy. But there is but the use of ticagrelor reduce the primary efficacy endpoint in patient with higher lower eGFR with CKD without any increase in major bleeding. As a limitation of this consensus, actually there is not much diverse consensus recommendation based on best available evidence and publication at the time. And this consensus actually not intended to replace the clinical judgment, and the use of P2Y12 inhibitor patient receiving oral anticoagulant is not discussed in this paper. In conclusion, when managing Asian patients who have had ACS with dual antiplatelet, there are different considerations compared to those in Western population. While data from Asian population comparing ticagrelor and prasugrel are limited, there is evidence to suggest that the ticagrelor or prasugrel should be preferred over clopidogrel in most patients in ACS, particularly in those who have undergone PCI. The decision on duration DAPT, including the need to de-escalate, stop or continue beyond 12 months, should be individualized, considering both the ischemic and bleeding risks of each patient. Thank you. That's the end of my presentation.
Okay, thank you, Dr. Dafsah, for the very concise presentation. And I think we're going to have the Q&A session after Professor Stephen James' presentation. I would like to introduce to you all Professor Stephen James, our second speaker of today's webinar. He is a professor of cardiology at Uppsala University, a very distinguished university located in Sweden. He's also a senior interventional cardiologist. And as a matter of fact, he's now sitting in the desk of his office in the hospital, getting his weekend on call, but still he has the time to share with us some of experiences and the result of the trial that he's been involved in. He's currently the president of the Swedish Society of Cardiology, and he's been participating in many guideline arrangements, and one of those is one of the bifocal guideline that we have used by far, the 2017 ESC guideline on ST elevation myocardial infarction. And he has been co-authoring several recent European guidelines on acute coronary syndrome and revascularization. And he has written and been involved in over 400 peer-reviewed cardiology journals. So thank you for sharing your time with us, Professor Stephen James. And I think I would like to share this time for you now, please. Thank you.
Thank you so much. I'm honored to be invited and to be participating in your event. Thank you, Dr. Dasdo, for that introduction, and Dr. Dafsah for the nice speech, starting this session for me. So I have a few disclosures. I have collaborating with many manufacturers of antithrombotic agents, stents, devices, etc. I don't get any personal fees from the pharmaceutical industry. Everything that I receive go back to my institution to research. I do get personal fees from Medtronic for proctoring for valvular heart disease and structural heart disease only. So I'd like to remind everybody that having suffering from a myocardial infarction or an ACVS event leads to a high risk of repeated events in the future. So this Swedish registry study, including almost 100,000 patients, showed that actually 1 out of 5 patients with an ACS will suffer a new event within a year, MI, stroke, or cardiovascular death. So 20%, which is a relatively high number. So the risk of repeated events is high in this population, independent of other risk factors. In fact, also an additional 20% of those who do not have their first event within the first year will still have an event within the coming 3 years. So the risk is high and sustained for a long period of time. This is Swedish patients, as I said, from the Sweetheart Registry. So I think we need to focus on long term, and we also need to consider what is the risk about. I think we have a little bit too much for a long period of time focused on the stent protection to protect stents from new thrombotic events. This observation study that we did a few years ago, also from the Sweetheart Registry, we tried to look at patients who had repeated events. Where are they originating from? And we can see for a longer period of time, long follow-up, you see 3,000 days here, you can see that most of the events were originating from either an indeterminate location or from a non-culprit treated lesion. In fact, in minority, the green line is representing the culprit lesion. So the risk of stent thrombosis and culprit-related repeated events is a little bit higher in the beginning, but it gets lower over time. So we shouldn't focus too much on stent protection and short-term protection. We should focus on both short-term, intermediate, but also long-term protection of patients for new events, primarily MI. And we also need to keep in mind that we are treating patients. We're not treating stents. We're not treating vessels. We know that these patients who have had an MI have a greater risk of not only MI, they have also a higher risk of stroke PAD, and vice versa. Patients with a PID and patients with a stroke do have an increased risk of MI in the future. So we need to consider the entire patient, not only the specific lesion. This is a patient I had not very long ago. It's a typical ACS patient. This is a lady who was born 1963, so relatively young to be an ACS patient. She was married, non-smoker. She had diabetes mellitus type 2 with a high body weight of 87 kilos, a BMI of 32, which is unfortunately more and more common nowadays. She also had a moderate renal dysfunction. She had experienced recurrent chest pain at minimum exertion for a period of time, which has not worsened, and she was admitted with chest pain and was pain-free in the emergency department a Sunday morning. So this is a very typical patient, nothing special about her, but she does have risk factors, and she is admitted on a Sunday morning. This is the EKG, AV block 2, ST depression in lateral leads, slightly low hemoglobin of 110 grams per liter, milligrams per liter. Creatinine is slightly elevated with a GFR of 35. Troponin is elevated. The plasma glucose is very high. Typical high-risk patient with an ACS, non-S elevation ACS with AV block and high risk. My first question, just to be, I don't have a voting system, but just for you to consider, when should angio be planned? Should it be performed immediately, within 24 hours, within 72 hours, or should we plan for a conservative management? I think most would say theoretically, you would like to have this patient being undergo angiography as soon as possible. Many would say within 24 hours, but in fact, that is not frequently occurring in clinical practice. And one can question, is it necessary and how important is it? The current update of the non-S elevation ACS guidelines from the ESC is a little bit inconsistent here, consistent in my interpretation. If you see at the top of the recommendation, they say here, first medical contact and non-S elevation ACS diagnosis. So these are patients with a confirmed non-S elevation ACS, which means that they need to present with symptoms and a troponin elevation, because MI is based on troponin elevation. Here they try to base them if they are presenting at the PCI center or not, if they have high or low risk. They do recommend immediate care of patients if they're at a very high risk. These are primarily patients with occluded circumflex arteries or very high-risk patients. These should be treated as STEMI. Many of these, as you know, 20% of the non-STEMI population do in fact have an occluded artery. That's the reason many nowadays don't discuss classifying myocardial infarction as STEMI versus non-STEMI, but rather, do they have an occluded artery or not? And these patients do not have an ST elevation, but they do have an occluded artery many times. They have very high risk, hemodynamic instability, cardiogenic shock, repeated chest pain. They should undergo very early invasive management. The rest of the patients are recommended here to have an invasive management within 24 hours. The inconsistency in this particular recommendation is that at the top they say all patients with non-S elevation ACS, but then in this box, they say, again, patients with an established non-S elevation ACS diagnosis, which means all patients. So I think it's a little bit too much to say that all patients should have an early angiography within 24 hours. That's very difficult to achieve. We can achieve that in a large university hospital within a city, but within a country is very difficult. So we need to handle these patients more selectively. And try to be selecting patients for early or late invasive management. This is a huge difference from previous guidelines that has said that you should look at risk factors and not send all patients to an angiography. Well, in reality, this patient, she came a Sunday morning, and the cardiologist on call did plan for an angiography within 24 hours, which was a good intention, but the cath lab was busy all day, and an angio was performed Monday afternoon. So that's 48 hours, or at least 40 hours after presentation, or 48 hours after symptom onset. this is very common all across the world, and particularly at least in Sweden. I'm sure it's also typical in Indonesia. So the question for you to consider: when do you think you should start a P2Y12 receptor inhibitor? Should you start as soon as the diagnosis is set with reasonable certainty? Should you wait until the angio is performed independent of time? Or should you, if you're not able to perform an angio within 24 hours, when should you then start? If you have a delay for 2 days or 3 days, when should you start a P2Y12 receptor? And if you don't do an angiography, when should you then start? So here, I think the guidelines are saying that you should not routinely pre-treat. And I would argue for a little bit against the terminology pre-treatment. I don't think it's adequate to talk about pre when we're talking about treating patients with a diagnosis. I think it's essential. Everything we do as doctors in medicine is that we diagnose patients. And when we've diagnosed them, we select treatment. Patients with a non-S elevation ACS are diagnosed with a troponin elevation. When they have a troponin elevation, they have typical symptoms. If you are satisfied with that diagnosis, you should start treating the patients. There's no pre. You need to start when you've diagnosed them. Pre suggests that patients should be treated before or after angiography, but angiography is not necessary for the diagnosis myocardial infarctions, and many patients do never undergo angiography. So I don't like the term pre-treatment. I think you should talk about treatment and decide on a personal level whether or not you're satisfied with the diagnosis. If you are unable to make the diagnosis clear, and you perhaps need an angiography to make the diagnosis, then you should not start treating the patients with oral antiplatelet therapy until you have completed the diagnostic procedures. Anyway, the guidelines say that pre-treatment may be considered in patients who are not planned to undergo an invasive strategy, but it's not recommended to do routinely. I do agree that we should not treat patients routinely if you're not certain, if you have not defined the diagnosis. If you're uncertain, you shouldn't start treating patients. Then you need additional diagnostic measures, and then you should start treating the patients. But for most patients, I think when you have set the diagnosis, you should start treatment because that lowers the risk. Just for a very quick period of time, I'd like to go through this recommendation because I think it's important to make clear that who are we treating. In previous guidelines, it's been stated quite clearly that you should, for example, the DAPT guideline from 2017, it says you should be start treating patients as soon as the diagnosis is established. I think that's the correct statement. This is a very big step to start saying do not treat patients when they're diagnosed. And I looked in our registry, which is complete. All patients in Sweden are captured in this registry. And in fact, many patients do not have an angiography. 20% of patients above 65 years of age and 50% of those above the age of 80 do never have an angiography. So when is pre if you don't have an angio, and when should you start treating patients? Among those who have an angio, most of the patients do not have an angio within 24 hours. In fact, 63% do not have an angio within 24 hours. So we're not able to give them this service. So I think it's essential to start patients when you've diagnosed them, independent on the time point of angiography. The reason they're arguing against pre-treatment is a couple of trials. It's the COAST, but please keep in mind, if you have reviewed the COAST trial, that this was about half a dose of prasugrel before and half a dose at the time point of PCI. The first dose was given 4.3 hours before PCI, so not 24 or longer, very short period of time before PCI. And the trial did not detect any benefit, but the duration was extremely short. 4.3 hours is very difficult to foresee a clinical benefit with such a short duration of therapy. There was, in fact, a higher bleeding risk with prasugrel half dose. So that was a concern that the patients bled more. But of course, if you expose them to a potent platelet inhibitor, they're likely to bleed more. But it's very difficult to see any clinical benefit within such a short period of time. Anyway, this is a very old trial that was published in 2013. Another trial that was referred to in this regard was the ISORACT-5, a trial that enrolled 4,000 patients, randomized them to receive either ticagrelor or prasugrel. In this study, prasugrel was shown to be associated with a lower event rate as compared to ticagrelor, but here it was differently given. Ticagrelor was given at a median 60 minutes before PCI, and prasugrel was given at the time point of PCI. So this is again not 24 hours. This is 60 minutes, just 1 hour difference between the two arms. And the results of this trial was consistent whether or not the patients had STEMI or non-STEMI. So it was completely clear that the difference between the two agents in this trial, this cannot be explained by starting treatment early or late. There are other factors that explain the difference between the two arms. So this study does not say anything about starting early or late pre-treatment versus no pre-treatment. The other trials that were referred to in this document were trials that in fact included patients with stable coronary disease, and the PROG-18 study in patients with elective PCI, which in fact showed that if you start treating early with clopidogrel in this case, you may have a clear clinical benefit. So this suggests, in fact, a benefit of starting treatment early. What was not referred to was the CURE trial. I think this is the best evidence showing that if you start early, you will see an early effect. Here, you can see in this Kaplan-Meier event curve that patients who were randomized to receive clopidogrel had a lower event rate as compared to those who were randomized to receive placebo on top of aspirin. And this goes hour for hour. You see a risk reduction after 24 hours of 34%. So here in the CURE, patients who primarily did not undergo angiography did have a clinical benefit coming very early. There are also meta-analyses that have shown that for major CV events, this is based on clopidogrel. These are observational and randomized trials showing that there is a significant reduction in cardiovascular events if you start treating patients early versus late. And in this meta-analysis, there was no clear price to pay in terms of increasing bleeding risk. So this meta-analysis supports the early start of treatment in patients in whom there is a delay to angiography and those who are not undergoing angiography. But anyway, the guidelines say that you should not treat patients routinely. I do agree that you shouldn't start patients treated early if you have not confirmed the diagnosis, because then you're exposing them to an agent that is associated with a high bleeding risk. And if they don't suffer from a myocardial infarction, of course, they shouldn't be treated with a potent agent. But the guidelines still say that ticagrelor is recommended, irrespective of the planned treatment strategy. So as soon as you have set the diagnosis, the guidelines recommend to start treatment with ticagrelor, because that has been tested in prospective randomized trials. So if I go back to my patient, which P2Y12 receptor inhibitor should we use? Should it be clopidogrel, ticagrelor, or prasugrel? These are three P2Y12 receptor inhibitors. Clopidogrel is less potent. Ticagrelor and prasugrel are both potent agents, equally potent, I would argue, and they give a consistent benefit, a consistent effect, pharmacodynamic effect on the receptor, whereas clopidogrel provides a fairly inconsistent and uncertain effect on the receptor. The recent non-escalation ACS guidelines recommend either of these three agents, prasugrel, ticagrelor, or clopidogrel, but they do specifically recommend prasugrel over ticagrelor in patients who are undergoing PCI as a 2A/B recommendation. The four first lines here have been included in previous guidelines. The last recommendation is a novel recommendation that has been debated quite a bit, and I'll come back to the discussion about this in a moment. The evidence for prasugrel over clopidogrel is a strong piece of evidence from the Triton study. The Triton study was a very nice study performed to show really patients at high risk. These are ACS patients who were not receiving any potent P2Y12 receptor inhibitor for a long period of time after their initial events. Then they were randomized to receive prasugrel or clopidogrel. And you can see that there was an immediate effect reduction in thrombotic events that was sustained over time. So there was a clear reduction in CV death, MI, stroke in high-risk patients with ACS undergoing PCI. Of course, with an increased bleeding risk, which is always the case with these agents. The similar evidence is strong for ticagrelor over clopidogrel in the Plato study. The Plato study was an 18,000 patient study that randomized ticagrelor to clopidogrel, and it was clearly shown that there was a reduction in the primary event rates, cardiovascular death, MI, and stroke. And importantly, this trial also showed a reduction in cardiovascular death, which is the strongest of all outcome events. So it provides a very strong suggestion and evidence that if you reduce platelet inhibition, inhibit platelet inhibition sufficiently well, but not to a level that leads to fatal bleeding events, you can save lives because you reduce the risk of AMI, stroke, but you don't expose them to a bleeding risk that tends to kill them, if that, so to speak, then you can save lives. And looking at duration, I think this provides an important figure. Looking at when should you treat patients, should you treat them for a short period of time or a long period of time? This is the first 30 days in the landmark analysis. This is the extended follow-up from 30 days to 360 days. And you can see that the benefit tends to be greater on long-term versus short-term. So it's not quite obvious to me to treat patients with potent agents only for a short period of time when the benefit is clearly shown for a long period of time also to prevent patients from suffering, not only from stent thrombosis, but also from repeated MIs, as I showed in my introductory slides. For Plato, the results were extremely consistent. We showed multiple subgroup analysis, and the benefit was extremely consistent, independent of the risk characteristics of the patients, whether or not they had STEMI and non-STEMI, if they underwent invasive or medical management, independent of age, sex, body weight, prior stroke, TIA, renal failure, diabetes. The benefit was extremely consistent with no exceptions. It was also important to see in those who did not have an angiography or did not have a PCI, they were, of course, very much higher risk. These were the patients who had no revasc. They were, of course, at higher risk as compared to those who underwent revascularization. And the benefit was consistent, but it was clearly associated with a reduction in all-cause death among those patients who had no revascularization. You can see that the absolute benefit is very strong in these high-risk patients with a reduction in all-cause death. It's very difficult to compare trials. Many have tried to compare the Triton versus Plato, tried to compare prasugrel versus ticagrelor. I would say that these agents are very similar in terms of the antiplatelet effect, but the trials were very different. The Triton study enrolled patients late in the course after ACS. So they were enrolled when the biomarkers were declining. You can see here that the troponin levels were declining. And then it's possible to ascertain and find a new myocardial infarction. A periprocedural myocardial infarction can be detected. In Plato, patients were randomized earlier, and half of them were pre-treated with clopidogrel. So it was impossible to detect a periprocedural myocardial infarction. That is the reason for the difference between the trial outcomes. The Triton study showed a substantial benefit in procedural events and in stent-related events, but in fact, it also showed a reduction in spontaneous events over time, very similar to the Plato study. So I think both of these trials have shown nicely that potent platelet inhibition is associated with a reduction in early events, stent thrombotic events, but also importantly, spontaneous events over time, which is occurring over a long period of time. Again, suggesting that patients should be treated for a longer duration. Again, comparing these two agents is very difficult. There are now several studies looking at the pharmacodynamic effects between prasugrel and ticagrelor. Many of them show that both of these agents are potent, most of which also show that ticagrelor might be slightly more potent than prasugrel, but it's also more short-acting, so it tends to be associated with a lower bleeding risk. But they are, in fact, very similar. This is a study by Alexopoulos, now back in 2012, showed that ticagrelor tend to be slightly more potent than prasugrel. So just going back to the now the only trial that have compared the two agents head to head, the ISORACT-5 trial. If I look back again in the Triton study, you can see that the clopidogrel event rate was 12 in the Triton study. In the Plato study, the clopidogrel event rate was also about 12%, which was expected after a duration of about 1 year or 1.5 years in the Triton study. The ISORACT-5 was a much smaller trial, enrolled 4,000 patients as compared to 18,000 in the Plato and 13,000 in the Triton. It had an expected event rate in the ticagrelor arm, but a much lower than expected event rate in the prasugrel arm of 7%. The investigators themselves had expected an event rate about 10 to 12%, but found an event rate of 7%, which was much lower than they had expected for unclear reasons. So it's really surprising to see the ISORACT-5 trials. In all trials that we have performed with more potent platelet inhibition, like PURE, clopidogrel over placebo, high dose versus low dose clopidogrel, prasugrel over clopidogrel, ticagrelor over clopidogrel, more potent agents provide a benefit in thrombotic events, but also an increased bleeding risk. In the ISORACT-5, in which two very similar agents are compared, they show a great difference between the two arms, which is completely, to me, biologically implausible, difficult, impossible to explain. In fact, I argue that the ISORACT-5 has so many methodological challenges so that it's very difficult to interpret. It was an open label design. The unexpected results was going in the opposite direction as compared to the hypothesis that the authors had set up. The event rate was much lower than the investigators had expected, 7% versus 13%. They had an incomplete follow-up in many patients, high loss to follow-up regarding mortality, very limited site-based follow-up. They had a very limited ascertainment possibility of myocardial infarction, which suggests that the differences between the two agents here are explained by other factors than the pharmacodynamic differences between these two agents. Therefore, we performed a so-called network meta-analysis. We looked at all trials that have included a comparison between either ticagrelor, prasugrel, or clopidogrel, and these were 12 randomized trials, including 53,000 patients. And when we looked at the results overall, summarized here, we could see that for overall myocardial infarction, prasugrel tended to be more effective than ticagrelor. But the reason for this was, as I explained, the differences in design between the Triton and the Plato, and that the Triton study was able to detect and discern per-procedure myocardial infarctions by design, which was not the case for ticagrelor. If we excluded per-procedural MIs and looked at spontaneous MIs, we could show that both of these agents were similarly effective. And they were also similarly effective regarding cardiovascular death, although ticagrelor was the only one that was significantly reducing cardiovascular death events. So go back to our patient again. What happened? Well, in this case, aspirin and ticagrelor was started at the time point of the diagnosis non-STEMI. Although routine pretreatment is not recommended in the guidelines, this patient was starting treatment. The cardiologist on call, was unable, of course, to plan the time point for the angio. It's impossible for the cardiologist on call to know whether or not an angio can be performed within 24 hours. So here, treatment was started at the time point of the diagnosis. And when the angio was performed, eventually about 40 hours later, there was a very tight proximal LAD stenosis, and as well as a proximal tight RCA stenosis. This is a very high risk feature, of course. If we don't treat these patients sufficiently well with oral agents, there is a high risk of thrombotic occlusions and repeat MI during the waiting time for PCI. Both of these lesions were stented successfully, and it was an uneventful follow-up during the hospitalization. Furthermore, the new and non-escalation ACS guidelines say that patients should have parenteral anticoagulation in the acute phase and when they're undergoing PCI. And they do recommend fondaparinux if the waiting time is long, but you can also give other anticoagulation strategies. What these guidelines say, which I think is important, that we should be careful weighing bleeding risk versus ischemic risk, and look at the risks of patients. I'm sure you are concerned about the Asian Pacific paradox that Dr. Dafsah was referring to in discussing, that we need to take care of patients, look at them individually and see what is the ischemic risk, what is the bleeding risk, and weigh that back and forth. We have developed a score that's called the P2Y12 score. That's one of many scores that can be used. It includes prior bleeding events, white blood cells, age, creatinine clearance, and hemoglobin. The most important ones is the prior bleeding risk. If patients have experienced a prior bleeding event, they are at high risk of having new events. Age is always an important contributor and a predictor of bleeding, but also creatinine clearance in hemoglobin. The problem with creatinine clearance is that high-risk patients with creatinine clearance, a low creatinine clearance, are at high risk of both bleeding events and ischemic events. So among the most important of this score, I think the most important are prior bleeding and hemoglobin. Those are the ones that should guide us most primarily. The P2Y12 STAPT score has been validated, and it says that if you are in it shows the cut point of 25. So if you're using this score, if they're below 25, they have a net benefit of long-term DAPT. If they are higher than 24, they have a long net harm of being treated with potent P2Y12 receptor inhibitors. The guidelines are recommending different strategies for long-term therapy. Patients at low risk of bleeding are recommended a 12 months duration of dual antiplatelet therapy with prasugrel, ticagrelor, or clopidogrel. But as an alternative, they're also recommended a combination of ticagrelor and aspirin for the first 3 months, switching over to ticagrelor monotherapy. This is now very nice shown in the Horizon study, and I'll show that in a little moment. This strategy has not been approved by all regulatory authorities, perhaps not in Indonesia, I don't know. So it maybe formally cannot recommend it, but the evidence is certainly there for giving monotherapy ticagrelor beyond 3 months in high-risk patients. In patients at very high bleeding risk or high bleeding risk, they are proposing to shorten the duration of DAPT to 3 or even 1 month, and perhaps also consider clopidogrel. But you need to be aware of the fact that if you are reducing the duration and reducing the potency of the agent, you are also exposing patients to an increased ischemic risk. Beyond 12 months, they are recommending either a combination of aspirin and ticagrelor primarily, or a combination with aspirin and a low-dose rivaroxaban, and I'll come back to the evidence behind that. For the long-term duration, we have at least a couple of trials that are informing us. The DAPT trial shows that over long-term, a dual antiplatelet therapy with clopidogrel or prasugrel is associated with a lower risk of ischemic events. These are non-stent thrombosis myocardial infarction showing a clear reduction over a long period of time. But it was, of course, also associated with a higher bleeding risk and no overall survival benefit. The Pegasus 1054 shows that continuing with ticagrelor, 90 milligrams or in fact 60 milligrams over time on top of aspirin, randomized to compared with placebo, shows a reduction in the primary endpoint, the CV death, MI, and stroke. So for long duration of time, up to 36 months, there is evidence that continuation with dual antibody therapy, preferably with low dose 60 milligrams, is associated with a clinical benefit. And importantly, I think if the time from P2Y12 receptor inhibition withdrawal to randomization of this trial, if that time period is short, within 30 days, there is a clear benefit. If there's a long delay in this trial from the time point when P2Y12 inhibitor were withdrawn, there is a much less effect. So it's logical to continue on ticagrelor for a longer period of time than stopping and reinitiating at a later time point. There is, of course, a risk of bleeding that we need to consider. Importantly, there is no significant difference in fatal bleeding events between ticagrelor and placebo. There is no significant difference in intracerebral bleeding events, but there is a higher risk in TIMI major or TIMI minor bleeding event, which we need to consider. So the question arises, of course, which is worse, to have a repeated bleeding event or to suffer from a repeating ischemic events? This analysis that we performed based on the Plato database, looking at different definitions of bleeding events. And so patients with a very severe bleeding, such as the Dasdo severe bleedings, a bleeding event tends to be worse for the outcome of death as compared to an MI or stroke event. But for Plato major bleeding or TIMI major bleeding events, there is no difference in ischemic events versus bleeding events. So if you have a very severe bleeding event, that's something you don't want your patients to experience because that increases the risk of dying from the event. But for Plato and TIMI major and minor events, they are similarly, or perhaps the ischemic events are more important concern for the patients. Just briefly, if you prolong DAPT, you will have a reduction in MI and stent thrombosis, but you will always have an increased bleeding risk. So this is the true dilemma. How do we weigh risk and benefit? And there are many trials now. This is an old meta-analysis, but there are multiple trials that have looked at this and different strategies, and we can never refrain from this combination. If you lower the risk of ischemia thrombotic, you will have an increased bleeding risk. The guidelines are now open more to de-escalation strategies. De-escalation is a term that has been developed to tell that you are starting with more potent agents and you are de-escalating to less potent agents after a period of time. This is possible, although I find it clinically not feasible. In the tropical ACS trial, patients were randomized to receive either prasugrel or a de-escalation strategy with starting with the potent prasugrel or clopidogrel, and then taking patients back for a platelet function test and testing if they were responders or not responders. If they were receiving if they were not responding to clopidogrel, they were switched back to prasugrel. If they were responding well to clopidogrel, they stayed on clopidogrel. In my clinical situation, it's not feasible to take patients back after 2 weeks, to take this analysis, to wait for the results, and then stratify them to different strategies. So I personally rather treat them with ticagrelor continuously and don't bother about doing this platelet function testing. I'm more personally attracted by the design of the Twilight study that, again, randomized patients after 3 months to stay on dual antiplatelet therapy or ticagrelor monotherapy. These were high-risk patients based on ischemia or bleeding. And you can see that if you give patients ticagrelor monotherapy, there is a much lower, almost half risk of BARC 2, 3, or 5 bleeding events, but there seems to be no price to pay in terms of increased ischemic risk. And this has been now validated in meta-analysis. This is a meta-analysis with 4 trials looking at this question, And you can see, that there is a clear reduction in bleeding events, but there is no reduction, there's no increase in ischemic events. There, in fact, tends to be a numerical reduction also in ischemic events. Another alternative, I think, which is attractive long-term in some patients, primarily in patients who have had prior MIs or stroke or ischemic events, but not ongoing therapy, is to provide them with an opportunity for low-dose rivaroxaban, as was shown nicely in the COMPASS trial, that rivaroxaban plus aspirin versus aspirin alone or versus rivaroxaban alone was associated with a clear reduction in ischemic events. Also, in fact, a reduction in cardiovascular mortality. So I think it's impossible to tell our patients post-MI, if they have been on ticagrelor and aspirin for a year, to tell them to switch to rivaroxaban. But I do think it's attractive if you have patients in your in my outpatient clinic who have not had an MI recently and are not on dual antiplatelet therapy, to have an alternative to treat them with low-dose rivaroxaban, particularly to reduce for patients with peripheral artery disease, which was a subgroup of interest for this trial. There also for this therapy is, of course, an increased risk of bleeding events, but the bleeding risk is not including fatal events or intracranial hemorrhages, similar to the Plato trial, so it does not affect overall survival negatively. Just finally, go back to my patient again. This patient, this lady, was treated with DAPT for 24 months. This was before we had introduced the Twilight strategy with ticagrelor monotherapy. Today, perhaps aspirin might have been discontinued earlier because she had a low hemoglobin. But on the other hand, she was young. She had not experienced a bleeding event previously. She tolerated DAPT very well. She got control over her risk factors. She was reevaluated at 12 months, and she had no events, no bleeding events, no ischemic events, and she had received much better secondary prevention therapy. She had started exercise, lost body weight, and therefore we stopped dual antiplatelet therapy after 12 months. If she had been at high risk or had had repeated ischemic events, she might have been continued on dual antiplatelet therapy per the Pegasus strategy afterwards. So I'd like to conclude here and say that antiplatelet strategies should be balanced based on risk versus ischemia versus bleeding. Ticagrelor and prasugrel are both very potent and fast-acting P2Y12 receptor inhibitors with a very similar pharmacodynamic antiplatelet effect, although they are different in terms of offset of effect and the irreversibility of prasugrel. Ticagrelor is the only agent that's shown a reduction in cardiovascular mortality after ACS, and ticagrelor monotherapy is associated with a low bleeding risk with no obvious price to pay in terms of increased bleeding risk. And long-term protection of spontaneous thrombotic events should be considered in high-risk patients. So that's my concluding slides. Thank you for your interest. I hope you were able to follow.
Thank you, Professor Stefan. It was a all-in-one kind of lecture that we could get. There was about the aspirin, the clopidogrel, ticagrelor, prasugrel, and we heard of a peak of rivaroxaban from the TAPAS trial. Thank you very much. And I think we have got some interesting questions already from the Q&A columns. There have been like 5 questions being raised for all of us here. And first, and of course, the discussion is open for attendees right here. You can raise your questions by putting on your by typing on the Q&A column here. First, from the Dr. Haris Muniwan, raising his question to Dr. Dafsah, and I think it's quite similar to the question that was raised by Dr. Muhammad Sukri. It's about the East Asian paradox. The question is like, for Southeast Asian population, like in our countries, where should we choose? We know that there is East Asian paradox with high on-treatment reactivity, but ischemia even was lower than that of the Caucasian population. The question was about whether we really need potent P2Y12 inhibitor, or probably we could opt for a lower dose of P2Y12 inhibitor. And also the quite similar questions by Dr. Haris Munirwan and Dr. Muhammad Shukri about measuring the bleeding versus the ischemia risk in Indonesian population. Dr. Dafsah?
Thank you. Thank you for the question. I think Dr. Haris and okay. As you know, the population is the East Asian population, and for the Asian paradox, and I think that's one of the reasons that the Asia Pacific Society gathered to see whether we have any different in or any evidence, more evidence in the especially in Indonesia or Southeast Asia population. And it turns out that unfortunately we don't have enough evidence on that, but the panel, I think, as shown in my presentation, basically 100% feel that we still need to use potent antiplatelet, considering that the effectiveness in preventing ischemic event is higher without bleeding risk, higher bleeding risk in population, general population. And we also know that in Plateau, I think around 10% is actually the patient come from Southeast Asia, and few of them also come from Indonesia. I think that's the reason behind, and almost 22, not almost, all the 22 panel involved, I think all agreed that we need potent P2Y12 inhibitor. But again, we also believe that you still need to individualize in terms of not only looking at the risk, but also risk of ischemic, but also risk of bleeding. And the reason why we don't recommend any specific risk calculator for risk of bleeding, because none of them have been validated in our population. Maybe that would be one of the tasks that we should do to validate the bleeding risk in our specific population. I think that's the reason for those recommendations. And again, given there is no specific calculator in general, in practice, I think I still use the available calculator to measure the risk of bleeding, despite that it needs to be validated in our population. That would be my answer. Thank you. Hello? Dasdo, you still mute.
Okay, all right, thank you. I would like to address the similar question to Professor Stefan in regards with the Southeast population, whether it will be safer for us to just use a more conventional clopidogrel instead of using a more potent, a novel P2Y12 inhibitor. What is your comment, Professor?
Yeah, that's a great question. It's a difficult one. As Dr. Dafsah said, and as was I've shown in our studies, in the Plato and many other large trials, the outcome, the ischemic risk and bleeding risk was very consistent across all subgroups that we could look at. We found very consistent results in ethnical subgroups, geographical subgroups, with very few exceptions. So I clearly think that the benefit of a potent agent is there. If clopidogrel was an agent with only a lower potency, it might have been attractive. but it's also the inconsistent effect, pharmacodynamic effect, which is a concern. There's no way except for platelet function testing to know if a patient is a responder or a non-responder. That is difficult to check or test in randomized trials, but I would feel very uncertain and concerned if I treat a high-risk patient with clopidogrel with an unknown response. The response rate varies considerably. I would be more attracted to use a potent agent with a consistent effect across all patients, but at a lower dose. Unfortunately, lower dose studies have not been sufficiently well studied with large power, but it appears to me that ticagrelor 60 milligrams as compared to 90 milligrams is of similar clinical benefit. When we designed the Plato trial, we were looking at much higher doses, 90 milligrams per day or 180 milligrams or 320 milligrams per day. And we selected the lowest dose, 90 milligrams. Perhaps we should have also tested prospectively 60 milligrams or 30 milligrams. There are only small trials that have looked at this so far, but I would more go to a consistent platelet inhibition with such as ticagrelor, and perhaps just reduce concomitant treatment with aspirin and to lower the bleeding risk in high-risk patients. That's a more attractive strategy for me.
Okay, probably this is another question. How do you deal with the breathlessness that people experience with ticagrelor in patients with high ischemia risk?
Yeah. So we were concerned about the dyspnea issue when we designed the Plato and in the early phases. In fact, a few patients do experience breathlessness or dyspnea early. Yeah. We in fact designed a specific trial to look at that. But when we were exploring all of Sweden, all patients were invited, we were unable to find patients with continuous dyspnea. All of them were reversible, so we had to stop the trial because we couldn't find patients. So when we really were looking at them, there were no patients with consistent or continuous problems. So my interpretation is that a few patients do experience this, but it's almost always overgoing. It's not consistent over time. If they do experience symptoms over a long period of time, I just switch them to prasugrel. Okay. I think that's a very good strategy in my hands at least.
Yeah, but we don't have that choice of choosing prasugrel in our country. What about you, Dr. Dafsah? You know, in my own experience, I've got people who refuse taking ticagrelor despite their high ischemia risk, and then I, of course, needed to change it into the more conventional clopidogrel. How do you deal with that, Dr. Dafsah, in your practice?
Okay, is the question they don't want to take it because of the cost, or they don't want to take it because
breathlessness? We're talking about
breathlessness. Okay. In my experience, I haven't found a lot of patient with breathlessness. There's a few that patient with breathlessness, and when you continue, the patient is actually the symptoms doesn't persist. So I haven't much experience with patient who's having a side effect of dyspnea. So that's my experience in patient using clopidogrel. I think I like to follow up in the question from the chat. Regarding
another question from Dr. Shukri in regards with the polymorphism rate in our population, and whether it is necessary for us to call for a genotype test, CYP2, C19, just to check whether they are suitable for clopidogrel or not.
Okay, I think we also discussed this in the paper, but I can share my view on this or my practice. Given that the benefit of the ischemic event, and if you stratified that the patient doesn't have a high risk of bleeding, I would, like Prof. James said, that I would prefer my patient on the stronger P2Y12. And then if it's in the high risk bleeding, of course, we need to know whether the prevention of ischemic event in this patient is adequate or not, ideally with reactivity test. That would be my practice in ideal situation.
Yeah, I think the next question is from Dr. Sukri. It's about the bleeding score. Okay, you have already answered that questions, but that there has not been any justification, no validated scoring for our population. Is it right?
Yeah.
Okay.
Yeah, it is difficult to validate all the different scores and strategies in different types of populations. I think for these general scores, of course, it would be good to do that, but it's very difficult to get power in smaller sample sizes. And I think we should look at risk factors the same way. I think a prior bleeding is a risk factor independent of ethnicity or location of living. I think a patient with low renal function, high age, low hemoglobin, prior bleeding are always risk factors independent of where you live and what your ethnicity or race. So I think they can still be used, although they are not formally validated in that specific population.
Okay, yeah, thank you, Professor. And there is another question from Dr. Bayusi addressed to Professor Stefan. Ticagrelor has 40% of platelet inhibition within 30 minutes after dosing with a peak evac in approximately 2 hours. Okay, considering that we may defer giving pre-treatment antiplatelet before knowing the coronary anatomy. When PCI is finally planned, would you consider giving crushed ticagrelor sublingually to achieve faster peak evac of ticagrelor? I think this it's a very unique question, whether you're gonna you crush it first and just give it like sublingual nitrate just to for the dose to peak faster.
Yeah, well, yeah, that's one of the delayed onset of action is one of the reasons I'm arguing against delaying start of therapy. That's why I don't like to give ticagrelor or prasugrel, for that matter, on the PCI table. I want to treat them as soon as I have diagnosis confirmed, because otherwise I leave the patients with poor level of platelet inhibition immediately post-PCI. It's okay most of the times to perform the PCI, but immediately post-PCI, when the heparin activity is going down, the patients have not yet responded well to the oral ticagrelor or prasugrel, they're leaving the cath lab with declining heparin effect. And then you're leaving them to an increased risk of early stent thrombosis risk or thrombotic complications. Personally, if I have not been able to treat them early, if they are presenting late, I give them intravenous agents. I treat most of the patients with intravenous cangrelor, and then I switch over to ticagrelor or a GP2B3A inhibitor. I do give crushed ticagrelor in patients who are intubated for cardiogenic shock. I'm no experience, or neither scientifically nor practically clinically, with sublingual lingual administration. I don't think there is any evidence for that. It may work, but I have not seen any clear data supporting that. So I wouldn't personally recommend it.
Okay. Do we have another question here? Okay.
Can I ask? I like to follow up, because I'm so glad that you mentioned about the pre-treatment in your talk, because especially in a non-STEMI patient, you mentioned that you feel that after the diagnostic in non-STEMI, I guess the diagnostic would be once the after the clinical and the ECG, of course, the non-STEMI after the enzyme result comes out. Is it after the enzyme result come out, or the anatomy of the coronary known? Because and the other thing regarding preterm, that's why I show in my slide that in our population, it's actually 50% of the patient who's hospitalized doesn't get any invasive procedure, let alone invasive procedure within 24 hours, as you mentioned. So I think it's very difficult to have a early intervention below 12 hours, even if we think we can, because at the end there is the lab busyness and also the availability of the lab. So in my understanding, the reason that you delay in the cath lab for treatment of the antithrombotic, I think it's from the Prasuga trial, that in case the patient is actually gonna go to cabbage, is it that's the reason behind it? Also there is no difference in STEMI population when you for the potent antiplatelet, when you administer pre-hospital and on the table, and also in the Prasuga trial. I'd like to you to have a comment and elaborate on that.
Yeah, good question and a good discussion. You know, the universal definition of MI states that to diagnose MI, you need a troponin elevation. That's the basis, in combination with a typical history and supported by EKG changes. So for a STEMI, it's okay to stratify therapy if you have a typical history with chest pain and you have ST elevations. Then you have a very high degree of certainty in your diagnosis, and then you can start therapy. For non-ST elevation ACS, you need a typical history, you need a troponin elevation to confirm an MI diagnosis. If you're still uncertain, if the history is not clear cut, if the troponin elevation is marginal, you're uncertain, you typically need to verify the diagnosis with an angiography or other diagnostic measures. As soon as you have, with a reasonable certainty, state the diagnosis, I recommend to start therapy. For most of my patients with non-ST elevation ACS, the diagnosis is not very difficult, and I can start early. In patients with STEMI, I think it's clear-cut in many patients, and I start directly. If it's unclear, if the history is unclear, if the EKG is unclear, I wait until I have the angio performed. I'm not very concerned about the question about CABG, because acute, immediate need for CABG is extremely rare. There is, at least in Sweden, less than a handful per year, maybe 2 patients per year in the country are undergoing very early surgery. In most of the cases, we do the complete lesion, stabilize the patient, send the patients to CABG within a few days after the acute event. STEMI patients hardly ever go to CABG. Non-STEMI patients may go, but you do the cath, you discuss, you decide on the CABG, discontinue ticagrelor, and after 3 days they can go to surgery, 3 to 4 days. So I'm not concerned at all about CABG, because I never see patients going acutely.
It applies very well to our community, because the access for our patients to an immediate heart surgery is extremely low here.
Even in the academic hospital. So that's the reason I brought it up. So if the patient's not going to be revascularized anytime soon, I guess from your elaboration, I guess when you say diagnostic is when you have a confident level that this is actually, the elevation is actually caused by ischemic event, the elevation or of troponin caused by ischemic event, which significant clinical clinical findings. Is that about right? The summary.
Yeah, absolutely. That's my interpretation.
Okay, somebody sent me a message from WhatsApp asking, addressing one question to Professor Stefan. Okay, from the ESC guidelines 2020 mentioned that in high bleeding risk patients, clopidogrel is recommended. Is there any place for ticagrelor or prasugrel in such category of patients, in high bleeding risk patients?
I do think so. I mean, some patients with very high risk of bleeding events also have a very high risk of ischemic events. So they're always typically following each other. But there are some cases. We had one patient here last week with a recent subdural hematoma, and then an MI. Of course, to treat a patient with a potent platelet inhibitor with an ongoing cerebral bleed or a subdural hematoma is very, very risky. And I would not recommend ticagrelor. I would perhaps stay with clopidogrel or aspirin only if needed. But I've also, in some cases with the moderate or high risk, I've also been exposing them for potent platelet inhibition for a very short period of time, and then withdraw aspirin immediately. So I've also, in reality, treated a few patients with ticagrelor monotherapy immediately. There's no trial evidence for this, but in the Plato study, we did use this for patients with aspirin allergy. And I have in my clinical practice some experience by giving ticagrelor only with no aspirin, perhaps a bolus or nothing. And it has, in reality, it appears to work. There's no scientific evidence for it, but in my practice, it appears to work.
So no aspirin, even within the first 1 month?
That has happened a few times, exceptionally. I mean, patients with extreme high risk, ongoing bleeding events, a recent or an ongoing subdural hematoma, but still a severe, high thrombotic risk. You need to find practical solutions to those issues. I remember we had also a fellow with a relatively small but intracerebral bleeding event, but a manifest huge thrombotic MI. What should you do? Of course, ticagrelor is contraindicated formally, but you need to do something. And with some degree of control, we were testing and on a daily basis and managed to get him through.
So a very random question from me. So people somebody unable to take aspirin, what about giving ticagrelor in addition to clopidogrel, double P2Y12 inhibitors?
I don't think that's a good idea. So the degree of platelet inhibition is large with ticagrelor, and you wouldn't add much by giving clopidogrel on top of that. So I wouldn't do that. I'd like to see in patients at very high bleeding risk. I'd like to see agents with a very short half-life, so you can get rid of the effect as soon as possible. So one alternative is, of course, to give them intravenous agents, but that's very complex and expensive in the long term. To give them cangrelor infusion for the first period of time, and which you can stop immediately, or heparin infusion, but that's not a solution for the long term. And since ticagrelor has the shortened period of action, it's quickest to get rid of it if you stop taking the pills. I mean, you can pretty much get rid of the effect within 2 to 3 days, as compared to clopidogrel, it takes up to 7 days to get rid of the effect.
Okay. Oh, I love your answer. I think it's very important for us to know everything. Do you have any other questions? Okay.
I do.
Okay. All right. Please, Dr. Dafsah.
Okay. I guess my question would be, I think from my understanding that actually the bleeding that impact mortality is mostly when the bleed event occurring within the 30 days after during the ACS event. Is there actually, and then most of the study use a safety endpoints long-term study for bleeding. Is this actually evidence that bleeding after 30 days is actually impacting mortality?
If bleeding events after the initial 30 days are impacting mortality?
Yeah. Because my understanding is the bleeding event that impact mortality is when the bleeding actually occurring within 30 days after the within 30 days of the ACS event. Like early bleeding that impacted long-term mortality. I like to confirmation since you're the expert in this field.
Well, I think there's evidence that both early and late bleeding events can be associated with negative effects on mortality, depending on the type of bleed, of course. So I think both early and late bleeding events should be considered important. Late bleeding events may not be directly related with the interventional procedure, but I'm concerned with late events as well. If I'm selecting patients for long-term antiplatelet therapy, if they had late events, that's a concern to me. And as you can see in the one of the slides that I showed, this study we looked at both short-term and long-term, and you can see for example with Plato and major and minor, short-term the MI stroke risk was greater in terms of mortality. On long-term, the bleeding events tend to be worse. So here it was worse to have a late bleeding event with effect to mortality as compared to an early bleeding event. That was primarily for Plato. For Tim and major, it wasn't that big of a difference. But in summary, both early and late bleeding events are concerning.
Professor, another question from Dr. Bayusi. He just sent me a message from WhatsApp. Thank you, Dr. Bayusi, for your concern. I think this is very important for us. The question is about in patients with high bleeding risk. Is there any space for us just to still give a ticagrelor with lower dose, or should we just switch to a less potent P2Y12 inhibitor?
I think personally, although now we're beyond the evidence-based space, lower dose ticagrelor 60 milligrams has been tested in the long term in the Pegasus long-term prevention setting. It's not been tested formally early post ACS. Still, I think from the pharmacodynamic data that ticagrelor 60 milligrams appears to be effective in reducing ischemic events with a more favorable bleeding profile. So without any evidence, I would be attracted by giving a lower dose in high-risk patients, particularly perhaps in the Asian Pacific region, but because of the pharmacodynamic effect.
Okay, I think it's very plausible to do that, but of course, as you just mentioned, it's not well proven by evidence yet.
Not at all, but sometimes we need to go also discuss beyond the evidence. We're doctors.
Yeah, tailored medicine. Dr. Dafsah, a question from a very good friend of mine, a neurologist, Dr. Ricky. Thank you for coming by and seeing us here at PERKI. The question is, people with clopidogrel or ticagrelor, when should the consumption be stopped?
People with ticagrelor or clopidogrel who had an ACS. I presume.
Yeah.
Yes, if it's an ACS, I think at least 12 months, and then after that you continue with the single antiplatelet. I think that would be the general recommendation. And then in the specific population with high risk of ischemic event due to the procedure, and I think there is evidence for using dual antiplatelet with a low dose of ticagrelor.
Okay, so by recommendation, so we always give 12 months of DAPT.
For ACS patient.
Yeah, for ACS patients. Okay, we still have 10 minutes left. Yeah, somebody also sent me a question again to Professor Stefan. For patients who have received ticagrelor monotherapy ticagrelor for 1 year, but still in high bleeding risk, like for example, he's diabetic, hypertensive with multiple risk factors. What are the best continuing treatment of choice in such patient?
Yeah, that's a good question. Here we still lack evidence also there, since the Pegasus was dual antiplatelet therapy, including 60 milligrams ticagrelor plus aspirin for long-term therapy. But if you have already discontinued aspirin at 30 days, and then at 1 year, what do you do? We don't have any evidence here either, but I would continue with ticagrelor monotherapy.
Monotherapy, 60 milligram?
60 milligrams without evidence. Or as Dafsah said, to go for aspirin monotherapy. But if you experience this patient as a very high ischemic risk patient and you feel uncertain that aspirin is sufficient, I think an alternative would be ticagrelor monotherapy to achieve a higher degree of platelet inhibition with an acceptable bleeding risk.
Okay, so with that, is it right for me to assume that you no longer send patient for genotype examination?
Yeah, no, I don't. I think, you know, we did a lot of studies on genetic determination, but I find it very difficult on a personal, individual level to use genetic information, genetic testing.
Okay.
It has been tested, of course, but on an individual patient level, I think I find it difficult.
Okay, one more question, Professor. They're very busy sending messages to me, and it's very direct to me. By your recommendation, in Asia population, which potent antiplatelet do you suggest? Ticagrelor or prasugrel? Do you have any data on that?
Yeah, there are sub-studies from the different trials, but there are very limited direct comparisons. As I said, both ticagrelor and prasugrel are potent agents. They are similar, have a similar potency pharmacodynamically. The differences are other than the potency. Ticagrelor is more short-acting. It's reversibly binding to the receptor. So it's a more flexible use. You can withdraw therapy with a shorter delay to a reduction in the clinical effect, which gives you more flexibility towards bypass surgery, towards other procedures. The scientific evidence for ticagrelor is stronger for patients who do not have invasive management, for patients in different risk categories, with the evidence of ticagrelor monotherapy versus there's no evidence of prasugrel monotherapy. There's a stronger evidence for long-term duration. So although the two agents are very similar in terms of potency and consistency, there's stronger evidence on ticagrelor. I don't think for the Asian Pacific population that there's very limited direct comparative data, so I can't say that there's any difference. If anything, it appears that most of the studies are suggesting that prasugrel has a slightly higher bleeding risk as compared to ticagrelor. But now again, I'm doing cross-trial comparisons, which is difficult. But in the pharmacodynamic smaller studies, ticagrelor appears to be slightly more effective also.
Okay. Yeah, in very short period of time in Indonesia, we're going to have a generic type of ticagrelor. So no longer Brilinta being the single medication of ticagrelor on the market. We're gonna have the generic type. What do you think about that?
Well, generic pharmaceutical agents should be have similar effectiveness, similar potency and side effects. So if that's possible, if it's the same agent, it should be similarly effective. My experience with generic prasugrel, which we do have also in Sweden, is that the price is the same. So price-wise, it doesn't make any difference. Generic prasugrel is priced the same as branded ticagrelor.
Oh, really?
At least very similar. Very no meaningful difference. So there's no benefit in terms of cost to the society with generic prasugrel versus branded ticagrelor. If the pricing is different, if it's considerably less expensive, and it's the same agent, it should be, of course, a benefit to the society with lower costs.
Oh, great. Dr. Dafsah, we are 7 minutes away from the end of our session. Do you have any comment? Do you want to ask further questions to Professor Stefan?
Yeah, I guess more on general practice. I find that most in regards to dual antiplatelet, but firstly, most I don't know, most my patients have GI problem or reflux problem, so I tend to use after 12 months, or even in patient with GERD, I tend to use not to use aspirin. What is your experience on that in your population? Is aspirin has given GI problem more often than the other like P2Y12 inhibitor?
Yeah, I think it's similar here as compared to many other places. The GI problems, we are very liberal in using proton pump inhibitors in patients with GI bleeding risk. Aspirin is primarily given for a long period of time. I think in the future we need to challenge long-term aspirin. The evidence for long-term aspirin lifelong is also very limited. The GI bleeding risk is a concern. A very interesting aspect in the study we're continually performing at the moment is a study on eradication of Helicobacter pylori. We are randomizing patients cluster-wise to have a HP test, and if they are positive for Helicobacter pylori, we're eradicating them in order to lower the risk of GI bleeding risk, because that's another risk factor that could be treated. I don't know anything about the incidence or prevalence of Helicobacter in your populations, but it's about 20-30% here, which means that if you do eradicate Helicobacter, you may have a lower GI bleeding risk, and patients would tolerate DAPT better.
Okay, great. And then the other questions, we know that statin has also important role in preventing acute event. Mm-hmm. So here we are in the economic sense. Is it more important after 12 months? Is it more important to continue high high potency statin or high potent antiplatelet, in your opinion?
Well, I don't think you can put these two different types of pharmaceutical agents against each other. I think both are important, but of course, patients with high LDL, we're very liberal in providing them with high dose statin therapy for a long period of time. I think there is very strong evidence for statin use, and we have a high prevalence of patients who are receiving high dose potent statins over time.
Okay, there has been a whole lot of questions be answered by Professor Stefan. Thank you. And I think now we have 3 minutes left. Do you have any closing remarks, Dr. Dafsah, for us?
Well, I guess there's a lot of for our population. I guess we, as I mentioned, that we don't have strong evidence, but I think given the robust data involving also some of them involving our population, I think we can still use it. And what's more important, I think we need to also individualize our treatment regarding the dual antiplatelet according to the ischemic risks and also the bleeding risks. Again, we cannot generalize to all patients. And then regarding the pre-treatment, I'm so glad that that I can ask that question now. We have to be, in regards of pre-treatment, actually what they meant is actually when we are not certain on the diagnosis, but once you're certain on the diagnosis based on clinical and also the troponin, then you shouldn't delay giving a potent antiplatelet. I think that's my closing remark.
And what is your last message for us, Professor Stefan? Thank you for giving me that opportunity. I think it's to evaluate patients, to not specifically look at stents or lesions, to take the entire patient into your consideration, to try to weigh your therapy based on the patient's expectations, risk profile, future, and act as responsible doctors. Please continue to review the literature. Please continue to be interested, question evidence, discuss evidence with the patient in your focus for the best of their treatment. And I wish you all the best for that in the future in your country. And thank you for inviting me, and thank you for providing such good care for your patients. It has been a privilege for us to have you here. And by the way, you didn't have any call today, no STEMI during these 2 hours. I have a non-STEMI now in 2 minutes. Okay, so I think it's very perfect time. I would like to say thank you to all attendees this afternoon. Thank you for joining us at this full 2 hours. It has been, I think it's very concise, it's compact, a lot of things going on. We have discussed about aspirin, clopidogrel, ticagrelor, and of course, those things are like the bread and butters, the kind of medication that we prescribe on a daily basis. And hopefully it has been a useful and educational webinar for all of us. I want you all to keep safe, everybody there, and let's keep promoting vaccination for all the nation in Indonesia, because it's one of the ways for us to get away from this pandemic. Professor Stefan has already shared to us beforewards that the rate of vaccination is over 60%. And now there is no single COVID-19 patient in their hospital. I think we are aiming for that point very soon. That's our goal now. Keep safe, everybody. Keep healthy. And I hope you have a very nice weekend. Thank you very much.
Thank you. Thank you very much.
Bye-bye.
Bye.